All right, this week's lecture is going to be over AV heart blocks. There'll also be a separate PowerPoint presentation and video upload on pacemakers and artifact. And this is really the last of the arrhythmias that you need to learn. Everything else that we talk about will include everything we've had so far, but we're going to get into axis, hypertrophy, ischemia, infarction, electrolyte changes, things like that as the semester progresses. So really, if you can, this is still foundational material. Make sure you understand these rhythms, but this is the last of them that you're going to have to learn for us, okay? So let's talk about the AV heart blocks. This is going to come from Chapter 11 in Mastering the 12-Lead EKG. And these are problems with transmission of the impulse through the AV node. So although it says block in the name, sometimes it's simply just a delay, an extra delay as it goes through the AV node. And then other times it's a complete block where the AV node fails to transmit the depolarization at all. Now, so AV heart blocks are delays or interruption in conduction between the atria and the ventricles, and therefore are called AV heart blocks. We have listed below here 5 different types of AV heart blocks, and all their names are given based on the severity of the heart block. So the least severe is your first degree AV block, and as we go on down, the block becomes more and more severe until we get to a 3rd degree or complete AV heart block. So through this lecture, we're going to walk through all of these different types. Because we're talking about blocks that occur at the AV node, the most important interval for us to inspect is going to be the PR interval. And we've already talked about that being an important part of our systematic interpretation of the EKG. And so now that we have got to the AV heart blocks today, you'll see how important that is going to become, because this is so important. Well, why is it important to look at the PR interval? Well, what's the PR interval stand for? So the PR interval begins at the beginning of the P wave and goes to the beginning of the QRS complex. So what's happening during this part? Well, we have the P wave, and that's atrial depolarization. And here in the flat segment that follows the P wave, this is where things have reached the AV node and we're experiencing decremental conduction. Now, you may remember decremental conduction. This is where things normally slow down through the AV node to allow time for the ventricles to fill up before the depolarization continues and they contract. So in this situation, what we have is a prolonged PR interval, or that may indicate that there's a block or delay going on in the PR interval. So we'll talk about that. So knowing the normal duration of the PR interval is very important. 0.12 to 0.20 seconds is the normal duration for a PR interval. So anything that we see, and we'll get into it here in just a second with the first degree AV block, anything greater than 0.20 is going to indicate that there's a problem, right? Well, that's exactly what we have in first degree AV block. Now, again, although it's called a block, this is really not a complete block that's happening, but an increase in the duration of the time that it takes to get the impulse through the AV node. So it's a delay in the conduction. The impulse comes from the atria, it reaches the AV node, we experience decremental conduction, but it's taking a little extra time now to get that impulse through the AV node and on down to the ventricles. So because it's taking longer than normal, the only thing that we have to know is really that it's a constant PR interval greater than normal, so greater than 0.20 seconds. It's important that you note that the PR interval will remain constant. As we get into some of these additional heart blocks, you'll see that the PR interval can vary. So the PR interval here in the first degree AV block is going to be constant and prolonged, just as it takes a little longer for the AV node to respond to the impulse. Now, the other thing you'll see is that there will be no missing QRS complexes. Well, what is this telling us? Well, it tells us that each impulse, although delayed when it gets to the AV node, eventually it's going to make itself all the way through and depolarize the ventricles. So it does not completely block the impulse, it's merely slowing things down. So as you can see in the example below, the PR interval, which should be no greater than 1 large block, is almost 2 big blocks here, or 9 small blocks in duration. That is prolonged. Now, if you were to compare that to each of the other ones, you would see that they have the exact same duration, and so that PR interval is constant. You'll also see that after every P wave, we get a QRS complex. There are none of them missing, and so this is our definition or characteristics of first degree AV block and how we can identify it. Here is a 12 lead of first degree AV block. Now, although we call it first degree AV block, it should be, in all completeness, we would call it a sinus rhythm with first degree AV block. Okay, the rhythm is not first degree AV block. The patient has a sinus rhythm along with a first degree AV block. So how do we know it's sinus rhythm? Well, first of all, we go through our systematic interpretation, and guess what? We've got a computer interpretation up here. I'm going to use that for the rate. So the rate is around 62. We have a nice regular rhythm. That's the next thing we're going to look at. The rhythm is regular. So we have a rate of 62 with a regular rhythm. The QRS complex is narrow. The next thing we would look for are the P waves. We would see that they're hard to find here because they're so far away from the QRS complex. But these are P waves here and here. And if we look over in AVR, again, a little difficult to find, but that's a P wave right there. So these are upright in 1 and 2 and inverted in AVR, so we have a sinus rhythm of some sort. Next thing we look at, right, is going to be the PR interval. And this is where it becomes very important. If we identify that P wave and we can find the PR interval, we see that it's prolonged, and we want to make sure that each one of them are the same distance, and they are, and that always after a P wave we have conduction and we have a QRS complex. So this is sinus rhythm with a first degree, a very long first degree AV block. So what can cause this? Well, it can be an absolutely normal finding in a patient that has an increase in vagal tone. So athletes are notorious for having excuse me, some abnormal heart rhythms like a junctional rhythm, first degree AV blocks, low atrial rhythms because of the increase in vagal tone that they have. So that's one possibility. Medications such as beta blockers, we've already talked about how they slow things down, and they can be a cause of a first degree AV block. Electrolyte abnormalities such as hyperkalemia, that's another possibility. Now, first degree AV block is rarely something that we have to treat or do anything about. We simply make a note of it on our 12 lead EKG interpretation. Now, on rare occasion, the P wave can be so far away from the QRS complex that we lose what's called AV synchrony. And so instead of the things working together, it seems as if things are almost flipped upside down because the P wave is so far apart. I would say the patient with this 12 lead may fall into that. You can see the P wave almost sits closer to the preceding QRS than it does the one that follows it. And so they may end up having what seems like the ventricles go first and the atria second, and the patient may experience some symptoms from that. On the rare occasion that occurs, if it is not caused by something reversible like a beta blocker or an electrolyte abnormality, the patient may require a pacemaker in order to get things synchronized again. Second degree AV block type 1. Okay, there are 2 types of second degree AV block, and this is the first one. And so again, they increase in severity as we move through the types that we discuss. Now what we see here is it's the AV node becoming increasingly refractory to each impulse. Go back to my swimming analogy back when I was trying to train for a triathlon. So when I was first getting started, and even I guess further in, I could make the first lap and do pretty well. I'd get to the other side, not be too tired. But by the time I had to go across the second time, I was increasing in my fatigue, right? I might have to pause a little longer at the end of the pool before turning around and going across. And my times weren't as good. I would be a lot faster that first time I went across the pool than the second time, and faster the second time than I was the third time, and so on. But eventually I'm going to fatigue where I just need to completely take a break. And so that's what's happening with second degree AV block type 1. You get this progressive lengthening of the PR interval. So each time that the AV node receives the impulse, it gets a little bit more fatigued. And so the next time it receives an impulse, it's going to take it longer to get all the way through until eventually it says, you know what, I'm just taking a break. And that's when we drop a QRS complex. And so if you look at the example down below, you can see that the first PR interval looks like it's almost of a fairly normal duration. The second is longer than the first, and the third is longer than the next one. And so then eventually what we see is that there's a P wave all by itself with no QRS complex. And that's because that AV node said he was too tired to send the impulse on down through the ventricles. Now, the length of the PR intervals of themselves does not matter. It does not have to be greater than 0.20 seconds to be involved in this block. Now, as you can see, the further we get along, the higher the likelihood that it's probably going to be prolonged like that, but it doesn't matter. The actual duration here is not of concern. It's the fact that there's a progressive lengthening from the first to the final PR interval before the dropped QRS complex. What you'll see is that the PR interval is always shortest right here after the dropped QRS complex, and longest right before the dropped QRS complex. The other thing I want to point out right here, it's called grouped beating, and all that means is that because there are some dropped QRS complexes here and here, what you get is the appearance of a group of beats that kind of land here in the middle, and that's a clue that you may have a second degree AV block type 1 or a type 2, as you see these beats kind of grouped together with the missing QRS complexes. So here's an example of second degree type 1. Again, the underlying rhythm here is going to be sinus or whatever it will be, and the patient will have a second degree type 1 along with it. So if we were to go through our systematic interpretation, the very first thing we want to look at is what? The rate. Okay, so if we were to do this, I'm going to just kind of ballpark it here, 300, 150, 100, 75, 60. So the rate is somewhere around 60. And obviously it is a bit irregular because we've dropped QRS complexes, but again, just to get us through here. So we're going to say a rate of around 60. The rhythm is the underlying rhythm is regular, but then we drop something right here. There's something missing, right? If we were to keep marching this out, we would see that there should have been something here that's not, and something here that's not. So that's a clue that something is awry. So we do rate, we do regularity. There's some irregularity here, so we have to consider as to what that is. But we also see that there's some regularity to it, right? There's some parts of it that are regular. In fact, we have what we call those grouped beatings here, here, and here. Okay, so rate of 60, the rhythm is regular / irregular. We look at our QRS complex and we see that that is narrow. The next thing we would want to look at is our P waves. We can find those in 1 and 2, and a little bit harder in AVR since I've covered it up, but there's one there, and that's the one that's missing a QRS complex there, and they're inverted. So this is sinus. Next thing we look at is our PR intervals, right? So if we look at the rhythm strip down here at the bottom, we can see that things are gradually getting longer, longer, and longer until we have a P wave with a dropped QRS, and that tells us this patient has sinus rhythm with a second degree AV block type 1. Okay, so that's how that goes. Second degree AV block type 1, again, this can be from an increase in vagal tone, an athlete, those types of situations, medications such as the beta blockers, the patient having an inferior MI. And just like a first degree AV block, often no treatment is required for these patients. Occasionally, if they're dropping enough beats, they're having a slow enough underlying rate, they may have to be given atropine if they're hemodynamically unstable. Again, that's not usually the case, but atropine if the rate is slow or if they're dropping several QRS complexes. Now, something to keep in mind is that second degree AV block type 1 has a few different names. One of those is Vinkebach, and the other is Mobitz 1. Sometimes people will use the term Vinkebach, and that's because it helps them to remember saying Vinkebach takes a walk. And that can kind of help you remember that PR interval is taking a walk further and further and further away from the QRS complex until eventually it walks off altogether and you have a dropped QRS. Mobitz 1 is just another name for that. Remember, there's two types of second degree AV blocks. So the first one is Mobitz 1, and the second that we'll get to in a minute is going to be called Mobitz 2. And that's this one, second degree AV block type 2. And this is going to be characterized by, instead of an increasing PR interval, it's going to remain constant. But what we see is that we have randomly dropped QRS complexes. So instead of the AV node kind of giving a little bit of warning signs that it's gradually becoming fatigued, we have all of a sudden, just out of the blue, no QRS complex. We've got a P wave, and the AV node just said, you know what, I'm done. And so oftentimes it's because there's a block that is happening at the AV node or actually below at the bundle of his. And because that block is so low, then you end up sometimes getting a wide QRS complex. And that's because the block is occurring below the entire his Purkinje system, and therefore you end up getting a wide QRS complex because it's really somewhat ventricular in its depolarization. Now, if you were to look at this, the P waves are going to march themselves out. They're going to remain nice and regular. And this is going to be a helpful clue because one of the other things that we've talked about along the way is with P waves and no QRS complexes can be a premature atrial complex, right? But because this is not premature, we know it's not a PAC. And so we'll get into how to decipher those a little bit more on one of the final slides of this presentation. But so the the P waves here will march themselves out. It's a randomly dropped QRS complex, and the PR interval is going to remain constant from beat to beat. Ignore this. This is not Mobitz 2. This is a high-grade AV block. They can look a lot alike. The reason this is a high-grade AV block and not a Mobitz 2 is because there's multiple dropped QRS complexes here. Now, if I was to cover all this up over here and cover this all up over here, and we had this, two complexes with one dropped QRS, that would look like a Mobitz 2. You would have a constant PR interval, and a P wave with a dropped QRS. And there's a good high likelihood that it's going to be wide complex 75% of the time because that block is below the bundle of his. This one also, this is why you need to carefully measure those PR intervals because I didn't do that. And once I kind of got to looking at this, I realized that this PR interval is gradually getting longer. It's difficult to see that maybe in the first few, but if you compare this one with this one, then you will see that it has indeed gotten longer. This one's almost 9 small blocks, and this one is almost 12. And so this is actually a Mobitz 1. Okay, so a Mobitz 1. Make sure you're measuring those PR intervals very closely so that you don't get confused like I did. This, however, is indeed a Mobitz 2. And what you can see is if we measure the PR interval, it remains constant each beat. We have a P wave and a dropped QRS complex. And a lot of times, although not always, that QRS complex is going to be wide 75% of the time. So that's a helpful clue. Second degree AV block type 2. Now, this is not caused by an increase in vagal tone. This is from things that are a bit more sinister, like an MI, recent surgery, lupus, hyperkalemia, and medications. All right, so the symptoms of second degree AV block type 2 are really going to be dependent upon the underlying ventricular rate and the number of dropped QRS complexes. So if the rate is very slow and the number of dropped QRS complexes is high, the patient may have fairly significant symptoms including fatigue, shortness of breath, chest pain, and even become hemodynamically unstable. And that could lead to syncope and even sudden cardiac arrest. Now, if the underlying rate is quick and the number of drop beats is very few, the patient might not have any symptoms at all. And so our treatment's really going to be based upon whether or not the patient's symptomatic. So if stable and really no significant symptoms, no urgent treatment is required. However, these patients are at risk to go into a complete heart block or third degree AV block, which we'll get to very shortly. And so because of that, we need to be prepared to have a pacemaker on hand, whether that be transvenous or transcutaneous, in order to prevent worsening of symptoms. Now, if the patient's unstable, and again, this is because the rate is very low or the number of dropped QRS complexes is high, then atropine is our drug of choice. If you think back to all the different rhythms that we've talked about so far, if they are slow and symptomatic, then we're giving atropine. Temporary pacing is also a good possibility, except for you have to remember transvenous pacemakers require some clinical expertise and training in order to put those in, and transcutaneous pacemakers can be very uncomfortable for the patient, and trying to use sedation in order to make it more comfortable can cause a decrease in blood pressure, and we're already dealing with a patient who is likely not stable. Look for reversible causes of this and fix those if you can find them. So high-grade AV block looks very similar to a Mobitz 2 except the AV block is a 3-to-1 or greater. So instead of just one dropped QRS complex, now we have multiple QRS complexes that are missing back to back. So if there were continued conducted P wave and then a conducted QRS complex, that PR interval would remain the same. However, when we get dropped QRS complexes, we have multiple. So you have a 3-to-1 AV block. In other words, for every QRS complex, there's at least 3 P waves, 1, 2, 3, and then there's our QRS complex. So we have a 3-to-1 AV block. And that's considered a high-grade AV block. So it's a little different than a Mobitz 2 and has its own special name. Now, so again, 3 P waves for every QRS. Because there are so many ventricular depolarizations missing or not taking place, the ventricular rate is very slow, and these patients tend to have symptoms. Here is a 12 lead of high-grade AV block, and again, you have at least a 3-to-1 AV ratio. There's 3-to-1, and so 1, 2, 3, 1, and that's a high-grade AV block. Third degree AV block, this is where the atria and the ventricles are completely working on their own, and there's no communication between the two. And when the atria depolarize, the AV node is completely blocked and cannot and will not send a signal down to the ventricles. So what you'll see is that the atria is doing its own thing, the ventricles doing their own thing, and each will be occurring at their own inherent rate. So the atria is going to typically be faster than the ventricular rate because the atria has a faster inherent rate than the ventricles. This is usually because of some type of conduction disease, although there are some potential reversible causes, again, medications being one of those. Oftentimes, especially if there's conduction disease present, these patients are going to require a permanent pacemaker in order to make things right. So here are the characteristics of third degree AV block. What you'll see are that there are P waves present, there are QRS complexes present, and the two have absolutely nothing to do with each other. So if you were to march out the P waves in this strip down at the bottom, you would see that they remain perfectly regular. In fact, you'll find that there's a P wave now hiding inside of that T wave. And the ventricles, they would be regular if they continue to march out, okay? And so they're doing their own thing at their own inherent rate, atria typically faster than the ventricles. Now, one way to look at this is that the PR intervals are going to be irregular or random. And that's because they don't have anything to do with each other. This is just simply random placement of the P waves and random placement of the QRS complexes. So you can see that these do not match up. Okay, so here's a 12 lead of third degree AV block. And of course, you want to make sure that as we take a look at the 12 lead, we walk through our steps. So make sure you're doing this on every 12 lead that you have. So that would still be rate, number 2, rhythm, number 3, this is going to be the regularity. QRS complex, is it wide, is it narrow? We're going to look at our P waves, and we're going to look at the PR interval. And the PR interval, again, is really where the secrets lie in the AV blocks. So if we were to take a look at the rate, we would have to calculate this. The ventricular rate and the atrial rate would be different because, again, they are being paced by two separate things. The atria are not communicating with the ventricles. So if we were to calculate that rate, 300, 175, 60, 50, so it's way down there. It's a slow rhythm, somewhere maybe in the 40s or so, right? So that's good enough for these purposes. Now, if we were to look at the P waves, we'd say 300, 150, 175. So the rate of the atria is somewhere around 75 per minute. And that should already be a clue that things are not right. And so we have an atrial rate that is different than the ventricular rate. If we look at the rhythm, the R to R intervals are going to be regular. And if we look at the P waves, we'll see that they also remain regular. So the atrial rate is regular, the ventricular rate is also regular. Now the QRS here is somewhat wide and almost has the shape of a delta wave. And if we were to look at it, it's just a little over 3 blocks in width, so we have a somewhat wide QRS complex here. The next thing is the presence of P waves, which we do have. And if we were to, and we look at lead 2, it's upright. Lead 1, it's upright. And AVR, it's inverted. So that tells us that what's coming from the atria is therefore going to be sinus in nature. Now, we need to take a look at the PR intervals. If we begin to inspect those, we see this one looks like a fairly normal duration, maybe a little long. Then we've got a P wave without a QRS complex. And then we have a P wave sitting right on top of the QRS complex. A P wave all by itself, well, actually it looks like it's all by itself, but look, it's connected over here maybe. It's really long. And what we see is that the PR intervals are completely random. Again, this is because there is no association between the atria and the ventricles. The atria depolarization is not leading to ventricular depolarization. They're completely separate. So a clue that this is third degree AV block is that you have random PR intervals. And we'll go into that in a bit more detail in just a minute. Causes of third degree AV block, almost 50% of the time this is going to be caused by a degenerative conduction disease. Medications, as we've talked about, are often causes of problems rather than solving them. And so we can see that beta blockers, calcium channel blockers, and digoxin are potential causes of third degree AV block. If the patient's having myocardial ischemia, hyperkalemia, and recent cardiac surgery, those two can lead to third degree AV block. The symptoms here, as always, are going to depend on the rate of the ventricles and the patient's underlying health status. If the ventricular rate is fairly fast, then the patient may tolerate things okay. If, in fact, it's very slow, which is usually when it's associated with a ventricular escape rhythm to pace the ventricles, the rate's going to be much slower. This will lead to symptoms such as shortness of breath, chest pain, and may cause the patient to have syncopal episodes. They can even end up having cardiac arrest. This is where the patient goes into what's called ventricular standstill. Let's go back to our first rhythm strip here. So what we have is that we have the P waves demonstrating themselves as nice and regular throughout the strip, but then we drop off these QRS complexes and we're left with nothing but a series of P waves. This over here is called ventricular standstill. Without ventricular contraction, we have no cardiac output, and this is going to cause the patient to go into cardiac arrest. All right, asystole. This is not an AV heart block, but I wanted to go ahead and have a place to mention it, and this is where we're going to do that. This is the absence of all electrical activity, and so there is no depolarization happening anywhere within the myocardium, not the atria, not the ventricles, nowhere. Nobody's home. And unlike on the TV shows and in movies, we do not give electricity. We do not defibrillate asystole. This is only treated with good quality CPR, chest compressions, airway, breathing, circulation, those types of things, and epinephrine. Epinephrine is given in the hopes that we can restart things. When people go into asystole, they are very sick, and very rarely will they ever regain an organized rhythm. Not to say that it never happens, but this is usually very difficult for patients to recover from. Now, something to keep in mind is that ventricular fibrillation, when those fibrillatory waves are very fine, very small, sometimes it can mimic asystole. So one of the things you'll learn about when you take ACLS is that they want you to increase the gain on the EKG monitor in order to take a look at these rhythms that look like asystole. The reason that you're doing that is you're trying to take those fine fibrillatory waves and increase the size. It's kind of like turning up the volume. When we say increase the gain on the machine, it's like turning up the volume. It's making things that might be very small look much bigger and much more obvious. So you want to increase the gain on the machine to make sure that the patient does not have fibrillatory waves. So why is that? Well, that's because these are treated completely differently. We don't defibrillate asystole, but we absolutely, without question, will defibrillate patients in ventricular fibrillation. So make sure that you consider that. Pulseless electrical activity. This is any organized rhythm that we would expect to see a pulse in, and we have no pulse. And you'll see this very often in patients who've undergone cardiac arrest. You're doing CPR, you're doing ACLS protocol, And after you pause to take another look at the rhythm, you may see an organized rhythm on the monitor. And it's always important that we check the pulse, because oftentimes the patient will be in what's called PEA, again, an organized rhythm with no pulse. It can really look like anything. It can look like a sinus rhythm. It could look like a junctional rhythm. But you must make sure these patients have a pulse during this, because oftentimes they won't. This is essentially the result of electromechanical dissociation, and the electrical impulse is not causing the necessary mechanical response. When you get into ACLS, and again, this is from chapter 10, make sure you know those H's and T's. These are the potential reversible causes for pulseless electrical activity. Now, there are, I want to talk about something called electrocardiographic polyuria. This is a term that comes from Dr. Alma Mattu. He's an emergency medicine physician who teaches at the University of Maryland. He's got his own webcast called ECG Weekly. You can subscribe to that, where you get a weekly case to kind of review EKG. Very excellent resource. He's also written a textbook that we've used in the past for homework. I think the last 2 years we used his textbook for that. But he's got something called electrocardiographic polyuria, and really what this means is that the EKG has too much P. If you've talked about urology stuff, that you know that polyuria just means too much urine. So too much P. It's just kind of a little play on words here. So this is a way to kind of distinguish between 4 different rhythms when you have P waves that outnumber the QRS complexes. So if you've got more P waves than you have QRS complexes, there are 4 rhythms that you should consider. One is a blocked PAC. The next, Mobitz 1, Mobitz 2, and a 3rd degree AV block. So if you have an EKG with more P waves than QRS complexes, then you got to think about one of these 4 rhythms. And the way you're going to be able to distinguish this really easily is looking at the PR interval. So let's talk about how we can do that. Here's a chart that you can find in your book, but also reproduced here on the PowerPoint. So one of the things about a blocked PAC is a PAC obviously is a premature atrial complex. So if we were to march out those if we were to march out the P to P intervals, looking at the regularity of the atria, the thing that we would see if it was a PAC causing this extra P wave is that it would come premature. So if you march out the P to P, everything's nice and regular, then all of a sudden you have one that occurs early and the QRS complex is missing. We have a blocked PAC. Now all the others will continue to remain regular. That atria is going to beat regular. It's going to be on time every time. So how do we distinguish between the remaining? Well, we look at the PR interval. If you go back to Mobitz 1, this is also called Winky-Bach. You'll remember that we get a progressive lengthening of the PR interval as that AV node gets more and more tired, more and more fatigued with each impulse that it receives. So we have an increasing PR interval in Mobitz 1. If we look at Mobitz 2, you'll remember that the PR interval remains constant, and it's a sudden drop of the QRS complex, a sudden just giving out. So the PR intervals in Mobitz 2 will remain completely unchanged. In 3rd degree AV block, because the atria and the ventricles are not communicating with each other, what we will see are completely random PR intervals. So if you can remember this chart, you'll be in great shape for distinguishing these 4 conditions that can cause more P waves to occur than QRS complexes. Let me show you a quick example of each of these. So at the top, we're looking at the P waves, and if we were to march these out, we would see that we would expect the next one to be here, but it's instead right there at the tail end of the T wave. So we have an extra P wave here with no QRS complex. It comes premature. That tells us this is a PAC. If we look at the next strip, we can see that we have a P wave over here with no QRS complex. So the secret is going to lie in the regularity of the P waves. And we see that that is all regular. And then we look at the PR interval. Does it remain the same, or is it getting longer? This one is obviously getting longer and longer and longer. And this is a Mobitz 1. Again, start out by measuring the regularity of the P waves. There's your extra P wave. The P waves are landing on time every time. They're nice and regular. So the secret's going to be to look at the PR interval. PR interval here, 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 and here all look identical. And if it's unchanging, that means this is a Mobitz 2. Last but not least, again, we'll look at the regularity of the P wave. They're all nice and regular. Therefore, that's going to rule out a PAC. Yes, there's one hiding right inside of there. And then we look at the PR interval, short, medium, short. This is randomly changing, so we have a third degree AV block. There you go. Feel free to contact me if you have any questions.